ischemia. Is it clear? Now, periventricular leukomalacia and ventricular hemorrhage can also be visualized by using the CTE scan. Is it clear? Or MRI if you want. Now, the other elements that you have to visualize is now in cases where you have cardiovascular bradycardia apnea syndrome can only be visualized by using a clinical evaluation. Is it clear? It's a clinical diagnosis. Patent doctors that also an atrial septal defect can be supported by using, can be confirmed by using a cardiac ultrasound. Is it clear? Now the next one is meconial ileus and all that can be first intestinal necrotizing enterocolitis can first be supported by using a plain abdominal X-ray, and on plain abdominal X-ray you're going to have signs of intestinal obstruction. Is it clear? Where you're going to have dilated bowel loops, provided it is small bowel or large bowel. Small bowel is going to be more central and it's going to be wider than taller, and large bowel is going to be more peripheral and it's going to be taller than wider. Is it clear? And for peculiarly for necrotizing enterocolitis, after the first phase of necrotizing enterocolitis, you have a second phase of necrotizing enterocolitis that can be seen under the X-ray, and it can be seen. You can see pneumocystis intestinalis. Is it clear? You see pneumocystis intestinalis. Is it clear? It's a pathognomonic sign of necrotizing enterocolitis. As you can see, air at the level of the bowels, pneumocystis intestinalis. Is it clear? For stress ulcer is a clinical diagnosis, but paraclinical you can use also a esophagogastroscopy in order to visualize it, to show that actually there is actually ulcer inside the stomach. Is it clear? Now for endocrine you can visualize for the level of the cortisol. Hyponatremia asks for the level of sodium ion, potassium ion, calcium ion. For acute kidney injury you have to ask for urea and creatinine, and you have to ask for urinalysis to know the level, if it has been is pre-renal or it has already gone to renal. You have also acidosis, you ask for the pH level of blood. Is it clear? So those are the different elements that you have to evaluate. Is it clear? For hypothermia, the only thing is clinical. You have to measure the temperature intrarectally. Is the best method of measurement. Is it clear? It's intrarectally, because there is going to be ischemia at the level of the skin. So don't measure the temperature of this children with via the skin or via the armpit, because there is already ischemia of the skin. So it's going to reduce the temperature. The temperature there is going to be fake temperature. So why the best temperature you have to measure is rectal, because it's more central. Is it clear? Now we have increased pressure, pneumothorax. You can visualize it, supported by using a chest X-ray, where you are going to have a lean de demoiselle and much air inside the pleural cavity. Is it clear? So and then confirm it by using all this the imaging, best imaging to confirm who is going to be a CT scan. The carbon dioxide increase, you also measure for the arterial blood gas, and you're going to have increased level of carbon dioxide. For the vasoconstriction, bronchopulmonary dysplasia, you only ask for a biopsy of the lungs to visualize the dysplasia of the lungs, and the retinopathy of the newborn is a clinical diagnosis where you can use a fundoscopy. Basically, use fundoscopy in order to diagnose that. So those are the investigations that you have to ask every time you have patients that have birth asphyxia, prematurity, or that. You have also a full blood count. In order to evaluate if the patient is having anemia, you must ask for a full blood count, and the full blood count is going to help you for the hemoglobin level. Generally, they are going to have macrocytic hyperchromic anemia because they are going to have low level of folic acid, as I've just explained. Is it clear? And if they have normocytic normochromic anemia, it's a problem of hemolysis or a problem of low level of erythropoietin production. Is it clear? So those are the different elements that you have to evaluate. You may have a leukocytosis or a leukopenia. Even if you have leukocytosis, generally in premature, the leukocytes are not functioning effectively, so they may be at risk of infection. So that's why every time that even if you have leukocytosis or leukopenia, it's always good to measure the CRP level, because CRP level is going to also tell you the if there's an inflammatory process taking place. So we are going to have the CRP level that is going to be important in that. After the CRP level, we also have the next one. After the CRP level, we have The next one, which is going to be you can also measure the prothrombin time and the partial thromboplastin time with the international normalization ratio in order to know if there is going to be any hemorrhagic disease of the newborn. Is it clear? For the thrombocytes and all that. So those are the different things that you have to additionally evaluate in this patient in order to understand them. Then you have to also evaluate for the blood group of the child, because these children can also be at high risk of having jaundice. I've forgotten to speak about jaundice in premature and these children. They are high level of having jaundice. So you have to measure the blood group, and you also have to measure the bilirubin level, total and conjugated bilirubin. You also have to measure in this patient. Is it clear? Bilirubin level, total and conjugated, you also have to measure in this patient, because they are at risk of having jaundice. The jaundice can be physiologic or it can be pathologic from infection, from ABO incompatibility, from racist isoimmunization and all that. You have to speak about that. Is it clear? So you have to speak about the calcium ion level that you have to measure and all that. So those are the different investigations. But you need to know that the protocol in our context is that every time you have a patient that is premature on day one, you always have to measure. You have to take the blood group, you have to take the full blood count, you have to take the CRP, you have to take the calcium ion level. Is it clear? So those are the general investigation that you ask for all the children. Now, if you realize that the child is jaundice or yellow, you add the bilirubin level. Is it clear? If you realize that the child, you also have the fasting or the random blood sugar. So those are the general investigation you have to ask for all premature neonate children or even low birth weight children. That is the general in our context. Now, if the child is yellow, you add bilirubin total and conjugated. Is it clear? You add bilirubin total and conjugated. If the child now is feverish, has fever, you have to add hemoculture. Is it clear? Always add hemoculture in the context. And you may also, provided that it is late onset neonatal sepsis or early onset neonatal sepsis. If early onset neonatal sepsis, you always have to do hemoculture. If it is late onset neonatal sepsis, you have to find the point of focus. Is it clear? If it is chest, you have to do a chest X-ray. If it is, you also do a putum analysis. If it is the urine, you have to do urinalysis. If it is the umbilical cord, you have to do umbilical swab. If it is skin, you have to do skin cap and analysis. So those are the different elements if the child has infection. Now, after evaluating for infection, you can also, so those are the different elements that the child, if the child is convulsing, you have to also ask for again the random blood sugar of the child, and you also have to ask for the electrolyte level. Is it clear? All the electrolyte panel, particularly the sodium, the potassium, the calcium, the magnesium, and the magnesium ion. So those are the different, the chloride ion. So ask all these electrolyte panel if the child is convulsing. Is it clear? So those are the different elements that you always have to put when you have a patient that has birth asphyxia. Is it clear? Now the next thing is going to be the management of birth asphyxia.